to the American Academy of Emergency Medicine's Justice, Equity, Diversity, and Inclusion section webinar, Safe Space Training. My name is Dr. Kristen Fontes. My pronouns are she, her, and I will be your moderator for tonight's session. We are super excited to have Dr. Zachary Silberman as our speaker tonight. So I will introduce him now. Hello. We're so excited to have you here. So Dr. Silberman is a PGY3 emergency medicine resident at Vassar Hospital, where he has special interests in toxicology, wellness, and education. He is a co-chair of the Emergency Medicine Resident Wellness Committee, a founding member of the Emergency Medicine Health, Equity, Diversity, and Inclusion Committee, and the Medical Student Education Chief. Wow. He promotes transgender and non-binary patient awareness through his work with the Nuvance Health Transgender Patient Services Task Force and provides education on transgender and non-binary best practices to residents and hospital staff. And if that's not enough, he's also the resident advisor for the Nuvance PATMDTA Teaching Academy, and before residency, taught competitive swing and ballroom dance. Dr. Silverman, it's such an honor to have you with us tonight. That's all I have, so you are more than welcome to take it away.
Awesome. Thank you so much. I am super excited to be here. Thank you for having me. I do a lot of things because I'm really bad at saying no. And it's amazing once you start doing a bunch of things, how all of them end up intersecting. So this is, the talk is going to be not just about sort of safe space education, but specifically, how do we use adult learning theory to teach safe space education in a more effective way to our residents and all of our adult learners across the hospital system? So let's hope that this works and get started. Here we go. And so in case you're wondering, PATMD is the Patricia A. Teagan MD Teaching Academy, which is just part of our whole hospital teaching academy. It's a great way if people are looking for ways to get involved with medical education and learning more about adult learning theory. Looking for teaching academies is a great way to get involved. Anyways, that's the plug. I digress. Let's jump in. I don't have any disclosures. If someone wants to give me some, I am open to them, but I don't have any right now. So objectives, a couple of quick ones. First thing, we're going to try to recognize some educational theories. We're going to apply the educational principles to a safe space curricula. And as a part of this, we're going to discuss ways to help facilitate safe space communication. So just a quick intro and some ground rules. Most importantly, this is a safe space to ask questions. If anyone here has any questions, please go ahead and ask. I would rather someone ask something and what they're worried, what they're concerned about being, maybe this is the wrong way to ask it. I would rather it just get out there, get asked. And part of the exercise is then figuring out, is there a better way that this can be phrased? Is there something else that we can do? But having the question out there in order to create the dialogue is so important. We're going to talk about this a bit more as it pertains to creating a safe space. The other thing is a more interactive component for this. One thing that I like to do when I do my safe space trainings is a flashcard exercise. When I'm doing this in person, I hand out flashcards to everyone in the room, and I have everyone on that flashcard, I have them write down 3 questions that they have or 3 things that they hope to get out of the training. So we can take a couple of seconds and just take some time, come up with a couple of things that you want to try and get out of this. And then as we're going through this sort of lecture training, you can go ahead and cross those off as we're able to address them. And then that way we can revisit them towards the end. So let's give maybe 2 or 3 minutes for everyone to write down a couple things. Hopefully that's enough time. Sitting in awkward silence is uncomfortable for everyone. So we're just going to move on, but feel free to pause this when you're watching it later to come up with more if you need more time. So let's kind of jump into our content. There are a lot of educational theories. Broadly, depending on what sort of resources you're using or what literature you're looking at, they broadly fall into these two categories: behavioral and constructive theories. Different texts are going to talk about different things, and then these expand out into even more different things, which I'm mostly putting here as a, in case you want to Google this later for further research, you can go ahead and look at these. I want to talk about two specific things that fall within constructivism. That of andragogy, and then a specific branch of social constructivism called the zone of proximal development. In general, though, behaviorism is sort of founded on the individual learns through experience. This is a thing, this is the classical behaviorism theory that's sort of taught, where it's learning occurs through this system of rewards and punishment, whereas constructivism is more of the learner having an active role in their own learning process. So let's talk about andragogy, which is also known as adult learning theory. Essentially, this has six assumptions that describe the adult learner. Adult learners, they're able to self-conceptualize. They choose what, when, and how to learn, and they want to participate in their own learning, their own planning and evaluation. It's experiential. Adult learners have their best learning, it occurs through experiencing material. And adult learners also come in with significant past experience, and this contributes to their own learning and contextualizes their learning. It's problem focused as well. They want to see the immediate application of what they're learning. And so they're going to seek out learning opportunities that help them solve these specific problems. With that, sort of another side of that coin is that adult learners are extremely internally motivated. Instead of needing an external motivation of, I have to learn for this test, it's, I need to learn this because it's going to help me. This is going to satisfy me internally and my desires. That's what's going to motivate the adult learner. And it's motivated by need to know. Beyond just the problem-focused learning, they need to know why this is something that they need. How are they going to benefit, and how will it help them solve future problems? This kind of describes the adult learner, and this really helps us format how are we going to construct material that best reaches the learner. The other thing that's important is this concept called the zone of proximal development, which is a part of social constructivism. This describes essentially a safe space for learning. In the center of this zone, in the center of this sort of learning target, are the things that people already can do. They can be done without help. They're things that there's not going to be any learning here because the learner is bored. A good EM example is teaching someone how to check a radial pulse. One time, that's going to be interesting. The rest of the time, that's not going to be a worthwhile teaching exercise. The outer is going to be a can't do, even with help. Even with help, the learner is going to be too scared to try and learn this. For example, taking someone to the OR and doing an XLAP or an open aortic repair is not something that an EM doc or an EM resident is going to learn from. They're too scared to learn in that environment. The middle zone is the can do with help zone, or the zone of proximal development. This is where the maximal learning happens, where with the assistance of a more knowledgeable other, the learner's going to be able to internalize that information and learn what needs to be learned. What's really important and how this pertains to safe space education is that by making learners feel more comfortable, we expand the zone of proximal development. and we let them feel safe, being uncomfortable, being challenged, but still being supported and being able to learn from it. So if we can create a good, safe space for the learner, we can help teach them what they need in the long run to be a better doctor and take better care of patients. So you put this together with andragogy and a couple of those other theories that I had up there earlier. It comes down to a couple of key points. This is kind of where a lot of adult learning theory distills down to. You want to prompt the learner to identify where it matters. They have experience. They already have some level of context. And if you can have them say why it matters, like maybe with asking them to do some flashcard exercises and write down what they think is going to be important and set their own learning goals, they are going to be more internally motivated to process and accept the material. There also needs to be some evidence as to why it matters. If you say, learn this, that doesn't matter, but you say, learn this because it affects patient outcomes, and here's specifically how, well, that's going to matter a lot more. We're all about evidence-based medicine. Let's use some evidence-based education as well. There also has to be an application. I think one of the frustrating things for me with a lot of these safe space education is that it's very nebulous, it's very esoteric, and it's very much like not something that learners can use on their next shift. Give them the tools that they have, give them the tools that they need to use the material right away so they don't forget it. And then, like we were talking about with the zone of proximal development, we have to let the learner feel safe and feel safely uncomfortable. Let them be challenged, but also let them feel comfortable being challenged. Create a safe space for the learner. And another important part is involve the learner with their own learning and their assessment. One of my favorite things is this idea of active learning. Having the learner participate in the learning process, they're going to get so much more out of it than being talked at. So I'm sorry for all of the talking at you that I'm doing right now. So we're going to further summarize this to 3 key points. And this is sort of the end of the adult learning part of this talk. We want to create a safe space module that motivates learners to retain the material and apply their past experience to better integrate it into what they're learning. To do this, we want it to be interactive, we want it to be learner-oriented, and we want it to be immediately applicable. So what I want to do is I want to take all these sort of concepts that we discuss and apply them to the safe space modules that I've been running for my hospital system and for my residency. So we're going to start with the most basic thing, objectives, and setting the stage. We want our objectives and we want to set the stage so that we target our goals to the specific learner group, so that we can involve the learner in setting their own learning goals. And very, very importantly, we want to create an environment where engagement is safe and expected. So how do we do that? Our objectives should be very specific take-home points that are, excuse me, sorry. These take-home points should be directed to the specific audience. I'm not going to come here to a JEDI-AAEM group and talk about safe spaces, because the reason everyone's here is because, well, they are aware of this. They already kind of know this sort of thing. They're going to be in the center of the zone of proximal development. So we don't need to talk about that. We can move on from that and talk about some other concepts and how it applies. We want them, again, though, to be very specific, very targeted. There's something in educational theory called Bloom's taxonomy, and you can use that have a bunch of verbs and the modalities in which those can be best taught. That's a great place to start if you're looking for ways of coming up with objectives. My general rule is for each 15 minutes of a lecture, you should have one objective, and they should be very specific. For my group specifically, we have a lot of IMGs in our residency, which is wonderful. That everyone has a lot of different experience with the LGBTQ and trans community. So I wanted to create something that was targeted to this group that was, let's go over the basics. Let's address our misconceptions. Let's create a space where people who have a lot of experience and people who don't have a lot of experience in that topic can learn from each other and can collaborate, because we're all going to be working together with all these patients. The next part of this is the intro and ground rules. These are the exact slides that I use. It's a safe space to ask questions. I want to encourage people to ask those questions that they're confused about without any fear of reprisal or of the presenter becoming defensive. This is an extremely charged topic, especially for other members of the community. And it's very, very challenging to be able to address this in an unbiased way that doesn't bring in past traumas that they've had in the medical system. Being able to create a safe space where people can ask their questions so that they know what to do the next time they encounter a patient who's a part of this group is imperative to creating a safe space for learners. The other thing is, I set out from the beginning, it's going to be an interactive session where people are encouraged to speak up, to collaborate, and ask all these questions. We also go by Vegas rules. Again, it's a safe space. It's extremely emotional. It's going to bring up things that maybe people aren't comfortable talking about. We need to let people know that anything that happens in here is going to stay in here. Any personal details are going to stay within the session, so that, again, people are more comfortable and feel safer discussing these extremely uncomfortable and potentially awkward scenarios. I also tell everyone phones down. I tell the residents to stop doing Rosh review and put their charts away. They can finish it after conference. I get a little giggle, get a little interaction. It's fun. And again, it's okay for them to change their mind. As they ask a question, if they find out they want to ask it in another way, I'd rather them just put it out there and we can work through it together, or the group can work through it together. I've gotten some feedback from a lot of people who to people who I've given this to, who have participated in other safe space modules, that this was extremely helpful and set the modules that I was doing apart from other ones in being able to create a safe space that actually felt safe. And the other thing that we do is the flashcard exercise, just like I opened with. I pass out flashcards to my learners. I have them fold them in half so that we can use them for later exercises for part of the more interactive curriculum. And I have them set their own learning goals for the session. It's also a sneaky little trick for me because I collect the flashcards at the end, and that's how I get feedback from my session. I say, oh, did my session actually deliver the content I wanted it to? And did the people who were a part of this actually get the content they expected? Or is there something missing? Is there something I can do better next time? This has been super helpful. It's a fun little cheat, and I'm really happy with it. So after we kind of set the stage and our objectives, we move on to our definitions and our content delivery. This is where we sort of say, okay, let's talk about the brass tacks. Let's address the evidence. I like to start with this sort of definition of a safe space. I use these two different definitions. I'm not going to read this slide. You can read the slide and can also use Google. But again, the amount of time that I spend on this depends on who I'm teaching. If I have a group that is a lot more familiar with the evidence, we're going to zoom past that, which is what we're going to do here. But it's going to address some uncomfortable things. Make sure that you spend some time doing it. So I talk about my safe space. I talk about, why does this matter? Here are the key points. I have all sorts of statistics that I can cite, but right now we're going to move on. The other thing that I really like are the Human Rights Campaign guidelines, this being a national organization that sets the standard for other institutions, which lets me say to whoever I'm giving this to, this isn't unique to us. Just because you may not have heard of it doesn't mean that other people aren't doing it. And I think this sets a great baseline. Because one of the things that I get asked about frequently is, well, we can't ask everyone their pronouns. In med school, I was taught, oh, ask everyone their pronouns. That's how you should greet them. But when you're in the real world practicing medicine, that's not feasible. We need to make our LGBTQ and trans patients feel comfortable. But we can also alienate our other patients who are not part of the community, who are less open to that community, and they're still our patients too. We need to find a happy medium, and that's sort of part of what this addresses and why I really, really like the way they states it, where it basically says, it's okay to assume based on gender presentation. If you're unclear, ask, and if you get corrected, apologize and use the correction moving forward. And I think it's fantastic that this is an official policy that sets a standard for other institutions. So after this, we get into the first awkward bit and the first interactive bit for the talk. There's a lot of vocab. There is so much vocabulary, and it is so confusing. What I do is I have everyone just raise their hand if there's something on this list that they don't recognize. It's a little bit of interaction, and it's a great way for everyone to realize, oh yeah, we all don't know things. We are all at some level of uncomfortability with this material. And I raised my hand too, because when I first read through this list, I did not know all of these terms. There are a couple terms that I highlight that are specific to go over just for time. Those being AMAB and AFAB, assigned male at birth, assigned female at birth. I talk about gender identity versus gender expression, GSM, DSG, and then I go through the rainbow alphabet soup that is LGBTQIA, LGBTQ+, LGBTQ2S. There's a lot, but we address it. We address a couple things, and then if we want to spend more time discussing it, we're able to. So this is sort of starts with a, okay, let's be safely uncomfortable together. The next part and kind of the last part of the definitions, the more didactic portion is going over pronouns. This is where a lot of people I find have confusion. And this is where I think people have the most questions, and this can have the most immediate next shift impact. People want to know, how do you ask someone their pronouns if you're not sure? And so we told them, hi, my name is Dr. Silberman. I use he, him pronouns. What are yours? And we talk about some of the other scenarios when it's important to ask about surgical history and why that needs to be separately asked and justified why it's asking. We talk about those sorts of things and why those are important, and we get a chance to practice using them. And that, I think, is the key thing, is that we need the chance to practice. And with that said, let's talk about some active learning pieces where I give people the chance to practice. What I do is we go through a couple of small group scenarios, and depending on the size of the group, I break up the large group into groups of 3 to 5 people. And I put up a scenario with a couple of prompts and say, okay, discuss. How do you address this scenario? 5 minutes per each scenario, and then we rejoin and share thoughts. An important point for this that I make sure to start with at the beginning, these are all real scenarios or based on real scenarios that have happened at my institution, that have happened to myself, that have happened to my friends in the community who helped me build this module. These are real scenarios that are happening in the place where your learners are and are happening to their patients. And this is why they specifically need to know this. But we start off fairly easy. You start off with a low level of discomfort. It's just, let's practice introducing ourselves. Let's practice using some pronouns and clarifying pronouns. And then what information do we need to get from this patient to treat them appropriately? Do we need to know their entire past surgical history, how far they've transitioned? No. They came in, they have ankle pain. Is it broken? Yes or no? Great, let's fix it. Or not. But there's a limited amount of information that we need. And if we're going to ask something, we have to justify why we need it. Next scenario kind of ramps it up. You have a gender ambiguous patient. And now they tell you what their pronouns are, but it's different from what's listed. And now you have a provider who's not doing this properly. How do you address this? And then from there, we move on to, okay, you're a resident. What happens if it's your attending doing this? What happens if it's a consultant? What happens if it's a nurse? What happens if they keep doing it? How do you talk to the provider if they keep doing it, whether it's intentional or not? How do you address this with a patient when the other provider keeps doing it? What do you do in your chart? And it starts to get more uncomfortable because, again, these are things that happen. I've also seen this come up with some of, I believe in the Filipino language, there aren't gendered pronouns. So they default to a single, Filipino speakers will default to a single gender pronoun in English. And I am sorry if I am misspeaking, but this has come up where someone who does not speak English as their first language, where Tagalog is their first language, they unintentionally misgender someone, but they don't understand the concept of misgendering someone because of English not being their native language. How do you address that? I don't know. There's no right answer to this. And being okay with being uncomfortable in that is part of how we learn this. But we still get the tools of, hey, if this comes up, how do I address it? The next scenario makes it a little bit more uncomfortable. Now we have a minor. Now it's not someone in the healthcare team. Now it's family. And now it's directly applicable to their care. How do you address this? How do you hide a patient's chart from a family member? How is it different when you consent them? We're safely increasing the amount of discomfort that we have when we're going through these scenarios so that our learners are comfortable talking about these awkward things that don't have a right answer. Again, this scenario happened to one of my patients, slightly modified, but she came in suicidal because she was worried her extremely religious family members were going to find out that she had a girlfriend. It's directly relevant to her care. How do we address that? I know what I did. Was it right? I don't know, but I think it worked. And then the last scenario, this is, again, something that happened to one of my friends. It's a little bit less less uncomfortable. It's more of a how to talk about surgical history and actual resources that are needed. And this is definitely more on the clinical side. This is something that I use more so with the residents. I didn't use this when I gave it to the chaplains or necessarily when I gave it to the nurses, but it helps kind of bring it back to okay, here's our case presentation. What do we do? So once we've gone through these scenarios, then we spend some time to wrap up. This is where we're able to give the patients the tools that they're able to use on their next shift. We've practiced using them. Okay, let's summarize. Let's give you the tools that you're going to use when you encounter this patient. So with this exercise, again, I have people split up in small groups, and I don't have those lists of things as do and don't. I have them go back to their flashcards and I have them come up with 3 do's and 3 don'ts. It's 5 minutes. They come back as a group, share them all together. Once we've done that, we talk about them, we come up with sort of a big collaborative list, and then I say, okay, this is what I came up with. This is what I use, and this is what my friends in the community use. And again, we can refer back to those human rights campaign guidelines, which are a great general rule. From there, we go back to the flashcards and we say, okay, let's revisit your goals that you set at the beginning of this exercise. Did we address them? Are there any other questions? Do you have any feedback? And then I give them the resource. Sorry. Not sure if my dog's coming through on the made it happen. I was pretty good on that. I give them the resources that I use, things that they can refer to quick and easily on shift. And then importantly, I feel comfortable with this as a member of the community. I put myself out there as an educator. I put myself out there as an educator in the environment where if you have a question, reach out to me. I am comfortable talking about this and being an advocate for my patients and being an educator. Our patients shouldn't have to be educators, so reach out to me and I can help with this. And I've had lots of people reach out to me. I've had attendings reach out to me from internal medicine when we had a non-binary resident start working at the VA. They didn't know how to address that. They reach out to me. They talk to me. It was great. We've had a couple of instances where nurses have reached out to me of how do they work with this scenario. And it's honestly been fulfilling and I really enjoyed it. And again, a big part of this is being able to create a safe space where people are not afraid to ask questions. After the whole exercise, I send everything out. I send a quick summary with these resources, our list of do's and don'ts, and the Human Rights Campaign guidelines. I send that out to everyone so they can have just okay, I don't know what to do. Here's my quick lookup. Where do I go for this information? So that when they need it, information is there. So, in summary, adults learn differently from the undergraduate learner, from the high school learner. There are different motivations. If we can understand these motivations, we can create better content that is more applicable to our learners. Safe space education requires specific attention to this because of the zone of proximal development. We need to create a safe space for our learners to feel uncomfortable, where they're able to ask these questions and get more learning out of it. And active learning is probably the best way to engage our learner and give them the tools that they need to use on their next shift with this especially uncomfortable subject. These are, again, some great resources. If you want some more information on educational theory, there's an ACEP Core Teaching Fellowship. I did the resident version of this. It was great. There's another one for junior faculty, which I can't wait to be a part of. There's all sorts of different teaching academies as well, whether it's local. University of Vermont has one. Our hospital group here, New Vance, we have ours. And then a MedEd Fellowship is going to have all sorts of information. And if you have any questions about this, if you want more resources, I'm happy to share my slides. Please reach out to me. My email's below. Yeah, so with that kind of summed up, I want everyone to go back to their flashcard questions and take a look at those. And if you're not here in person, you can just email me what your questions were and whether they were addressed. But if you are here in person and you want to share, I'd like that.
Awesome. Thank you so much. This is wonderful. One of the things that I wrote down, and I think we kind of like you kind of touched on it when it comes to, you know, how do you like address a colleague, or depending on what their sort of level is, if you need to give feedback, especially when it comes to misgendering. And it was kind of making me think of times in the past where it wasn't necessarily like another coworker, like outside of the room, out of, you know, out where the patient wasn't present and hearing everything. But have you ever gotten, you know, either ideas from learners that you've taught, or sort of, yeah, feedback on experiences with when you're in the room with the patient and it's their parent, if it's a, a minor child, if it's, something that's happening kind of in front of the patient, especially if it's a relative and someone that they have an established, relationship with, and maybe one that, especially in the case of a, like transgender youth, like they're sort of on a journey together when it comes to transition. Do you have any thoughts, advice, reflections on that aspect?
Yeah, one of the things that when I went through this scenario with some of the nurses and also with the chaplains is realizing how many resources we have in the ER to, if we need to, just get someone out of the room. It's really easy to enlist the rest of the healthcare team. It's really easy for the nurse to come in and say, hey, let me pull you aside. And then you're able to talk to the parent, and then you're able to talk to the patient independently so that you can have that one-on-one time in a way that's just really subtle. Nurses are really good at their job, and they're really good at that. So being aware of all the different resources in the healthcare team is super helpful. And that was definitely highlighted for me when I was working with some of the other groups.
Awesome. I had another question about, I like through my education and career and some work that I've done like sort of on the side. I feel like I've been through several now safe space trainings, which have all been wonderful. And I think that one thing that continues to come up for me, and it's usually like in the clinical environment, is how do we create almost like, or not even create, but like extend the safe space to our documentation. And I say this as someone who has been through like lots of different electronic medical record systems. Like I used Epic for the longest time, and Epic does have, I think, like a good start to, um, implementing pronouns and someone's chosen name, and even on an ED track board, like you can see right there, so you don't necessarily have to look or search through the chart to know what name and pronouns a patient uses. Now that I don't use Epic anymore, it's a little bit less user friendly. It's a little bit less structured. There might be a place to sort of free text just information about the patient. But and this might be like, I don't know. I don't know if there's like a great like sort of single answer for this question, but do you have any um sort of teaching points about, how do we make sure that whether or not the patient has access to their medical record, which a lot of people do now, and a lot of people do want to read their notes, um, how do we make sure that our charting is also safe, and that our just the way that our sort of official documentation looks?
Um, Great question. As someone who is not quite lucky enough to use Epic, we have Cerner. Um, so I think in the clinical environment, where Cerner is not quite as well enabled as Epic is, um, there's a lot of room to free text stuff. We're slowly getting some of the capabilities. So one of the terms in that vocabulary list is SOGI, sexual orientation and gender identity. And that's frequently referred to in sort of EHR documentation. Different electronic health records might have a SOGI module that institutions are able to pay extra to get access to. And that'll help bring all of that in there. What I do when I do is I will, in the comments, I will highlight patient's preferred name and patient's preferred name and their pronouns. I will highlight that, make sure that it's visible, and then I will go to their nurse, their tech, my attending, anyone else who's going to interact and say, hey, this patient is this. They are listed in Cerner as this, but this is how they actually like to be called, and these are their pronouns. And I've gotten great responses for that. In my chart itself, I am really careful about drag and dictation errors. I worked with a plastic surgeon who did gender affirming surgery and got blacklisted in the community because of drag and dictation errors, because someone looked at their chart and this plastic surgeon didn't go through. And so the patient looked through their chart and said, I've been horrendously misgendered. And it was because of drag and dictation errors. So I'm very, very careful about that. And then the other thing is using descriptive language that gives us the information we need. This is where those terms AMAB and AFAB are helpful. 23-year-old male, assigned female at birth, presenting with. There it is in the beginning, and then it's done. And if there's ever a question, you can use gender neutral language, the patient states, or you can just use the patient's name. If there's ever a question, you can just use gender neutral language or use the patient's name. Pronouns take the place of the name, so just use the name if there's a question.
Right, thank you. So you've been doing this training for a minute, it seems, at your institution with multiple departments and different disciplines within the hospital, which I think is amazing. How did you, I guess, like maybe just give us a sense of like, when you first entered your residency, was there something that was already established that you built on? Did you build this from the ground up? And regardless of how it started, like just looking back on the time that you've been involved and kind of met people and helped to really help people feel like comfortable with even asking questions, because I think that's probably a big hurdle for a lot of institutions, with whatever the sort of culture is when you step into an environment like that. Like, how has it been for you in terms of like building, developing, and then kind of looking back on how far you've come?
It's been wonderful. I am extremely fortunate. Our institution is very, very new in terms of having residents. I'm going to be part of our second graduating class. And one of the great things about that, and one of the terrifying things about that, is there's a lot of stuff that just hasn't been done. Not because there's opposition, but because no one's thought about doing it yet. There haven't been residents who've thought to do it. So honestly, what happened with this was I noticed we didn't have any sort of education, and people had a lot of questions. As someone who is out and openly gay, people were coming to me with questions. I thought, let's get some education. So I found a community group initially who were able to do some trainings, and I got some feedback about them that the trainer was getting very defensive and was not giving us things that were applicable for emergency medicine specifically. So I thought, well, I'll just do it. Why not? And so I worked with other members of the community. I went through so many different resources to put something together. And I went to our program leadership and said, hey, can I do this? And they said yes. And then I did it. And it was awesome. And then they said, oh, we should get more people doing this. And so I was able to talk with some of hospital leadership. I was able to talk with department leadership and that sort of spread it out. And so that's how I was able to teach nurses and work with them. And that's kind of how it became a thing. And I think the most rewarding thing, and I don't know how much of a role I had in this directly, but I think the most rewarding thing for me was at the beginning of this year when we had our new interns come in. One of the interns who's openly gay came up to me and said, this is the first time that when I talked to an attending and said that I'm gay, it was just a complete non-event, and I felt so extremely welcome. And that, for me, just made me smile from my toes to my ears. It made me feel like, okay, I did something pretty cool. And I know it changed at least one life. I'm sure through this it's reached out and helped a lot of other people, but hearing that just gave me the biggest grin.
I love that. That's such a beautiful story. I mean, I think it just like, I think what kind of comes up for me, like as you were speaking, was like, just like it matters so much for patients to like have a doctor who looks like them, whether that's because of like shared race, any other sort of like identity, um, congruence between patient and physician has like just such a like it can really have a profound impact on the patient's outcome, whether it's just having a better experience, or even like I've seen studies on just sort of compliance, if that's the right word to use, when it comes to, taking their medications and things like that. And I just I think it's also a good reminder to, like you covered in your lecture was, we all have something to gain, and we all have something in here, like a personal stake, like that we will benefit from, um, if just by getting on board. And if it just makes, one person, whether it's a trainee, a student, a coworker, a patient, feel seen. I mean, I'm with you. Like for me, that's something that I carry with me for like not just that whole shift, but then I bring it home and I sleep better. And like it just seems like the sort of usual like, you know, workaday stressors um just don't really seem to take up as much space anymore. And that's beautiful. Um so hopefully especially for folks out there who, may not have like a personal connection to the LGBTQIA plus community. Um, we all do benefit from kind of bettering ourselves. Um, in addition to, I think, doing right by our learners and our patients. So I really appreciate that you shared that story because that's really amazing. Um, Well, I want to make sure that if there are any other like questions, discussion points, anything that we can use in these last 10 minutes that we have, like I am, we're definitely wanting to encourage that. So if anyone has any like feedback, other questions for Zach, um, I know I could probably talk about this for hours more.
It's such a fun topic. It really
Yeah.
is.
No questions, but thank you. I don't think this was even thought of as a topic when I was in residency.
Well, thank you for joining.
Yeah.
I appreciate it. This is, again, it's been, thank you for giving me a space to talk about this. It's a super personal topic, and I'm honored to have the opportunity to share it.
Thank you. Um, Yeah, I think that was a really interesting point that Kathy just made was like, I mean, even for me, I was like, I kind of still consider myself like early career, but I guess I'm not really anymore because it's been 10 years since I finished residency. But like, even for me, like coming up, like my medical school did offer a safe space training, and that was, 2007, which kind of feels like a long time ago now. But even since then, like the number of things that have changed, and I do feel like I got like pretty good education from queer identified faculty when it came to like taking a sexual history and like asking questions, in sort of like an inclusive way. But even then, I remember being asked, and at the time I started residency, like people were amazed that, when I asked a patient if they were sexually active and they said yes, and I kind of made it like it was men, women, or both at the time. And that was so progressive. Or at least it was sort of perceived that way. And it really has just become a matter of like, no, that doesn't even sound right anymore. Like is it, men, women, other genders, like, just kind of leaving it as open as possible. But I think it's just a good reminder that as physicians and also just as human beings, like, we're lifelong learners, and it's always a good thing to try and just make sure that we stay not even just up to date, but just stay, I think, aware and try to do as much as we can to, just provide that space for our patients and for those that are working around us. So,
Yeah.
all right. Yeah.
Awesome. Yeah, I have one of those sort of circumstances come up when talking about the word queer as something that had been used previously as a derogatory term. The community has just taken ownership of it as just ways that language changes. But yeah, I think the most important thing with any of this is create a space where people are not afraid to ask questions so they can keep learning.
All right. Well, with that, I would love to extend just a huge amount of gratitude to Dr. Zachary Silberman for this incredible piece on safe space training. Hopefully, folks can take at least one, learning point home with you to your own institution, and use that to not just educate yourself but also those around you. This has been a really great session. We will have a recording up usually within 24 hours of this session to the JEDI-AAEM website, and then it will also appear on the AAEM YouTube channel. So there will be plenty of ways to take a look at this after the fact. You can also find information on any upcoming events on the JEDI-AAEM website. There's also a way to register for upcoming Zooms and whatnot. So use that as your kind of home resource for everything JEDI. This will actually be our last mentorship session of the year. We'll be taking December off for the holidays. So I just want to wish everyone a wonderful holiday season, whatever that means for you. I know a lot of us, myself included, in the emergency medicine world, we're probably going to be working. But just know that it's been an absolute pleasure and certainly an honor to be able to share this space with all of you over the last year. And we will be back in 2024. So thank you so much, Dr. Silberman, and for anyone that's checking this out. And I wish you all a wonderful evening.
Thank you again for having me. Happy holidays, and I'll see you all in the cloud, I guess.
Thanks.